My name is Martin Pham. I'm a neurosurgeon at UC San Diego. And here I have Jonathan, one of the talented fellows here at the Seattle Science Foundation. And what I'll be talking to you about is the robotic system, right? So first, I'd like to, of course, thank all the wonderful industry sponsors who've been so generous in terms of making this happen. And thanks, of course, to the Seattle Science Foundation for inviting me and for all the wonderful talks that have been going on so far. I will say, like multiple people have said already, the Residents and Fellows course is one of my favorites because, the attendees who are all trainees and mid to late training really get to learn all of the fundamentals from so many of these experts in the field. And you can use so many of these analogies, but you got to walk before you can run. You got to dribble before you can shoot your three-pointer. You got to block and tackle before you run into the end zone. And I think a lot of the times we get so focused on all these cool procedures, right, like Dr. Uribe are doing and Dr. Mendel, but sometimes just like the paper in front of you, right, the ABCs of nerve decompression, getting those fundamentals first is necessary so that you can continue to build on all of your talented skills. So thank you. That being said, it's sort of ironic because I'm about to show you one of the most technologically advanced pieces of enabling technology equipment that we have to build upon your fundamentals. This is one iteration of a spinal robotics platform, and there are several that are on the market right now. This is the one that I'm most familiar with. To give you an overview, what you have here is a multi-jointed kinematic arm, right? So it's a CNC machine, same as the CNC machines that build your phones and build your cars and build your spaceships. And now there's one that we can use for spine surgery. This particular platform is mounted to the bed. In addition to its mount to the bed, it's also mounted to the patient in an effort to increase stability to minimize error. Right? Within the arm guide here, there are optical cameras that also take a picture of the operative field, again, to increase patient safety so that the robotic system understands where the patient is in three-dimensional space. Now, there's been a lot of talk about the robotic systems and how it's different than really just an arm sent with navigation. And I think one of the examples that I always like to show is here, the system is integrated with navigation, right? So you can see moving my marker, and on the screen here, the system tracking where the marker is. So if I were navigating a screw, I would find the entry point of the screw, just like Okonkwo showed earlier. And once I find that screw, I would keep it there, and then under live navigation, place everything. So if the arm was sent by navigation, then the arm would need that real-time feedback as well. Right? But the difference between robotics and navigation is that the arm is independent. Right? So for example, if I were to cover the navigation right here, I feel like I'm doing a magic trick here. If I were to cover the navigation, right, I'm no longer live, right? So I don't know where I'm going, so I can't place a screw under navigation anymore. But can you go ahead and send the arm? But the arm knows where the patient is already in three-dimensional space. So the arm is still being sent to L3, even if I can't physically see it as the surgeon. So how is this different? The difference, and the analogy I make, is sort of like when you think of a Tesla, right? And when you sit in your Tesla and you turn it on autopilot, and say you set the car on autopilot and you tell it to go from work to home, and say you just black out all the windows. So you as the driver can't actually see where the car is going. The car is still going to take you home. And so this machine is still the same concept. The CNC machine understands where the patient is in three-dimensional space based off of those registration x-rays, even if you as a surgeon can't see it. But the navigation allows you to see. So equivalently, in the Tesla, if the car is taking you home, now you unblack out the windows, you can actually see where the car is taking you to make sure as that second check, right, a human eye check, that the system is as accurate as you want it to be. Similarly, the whole point in having all these demos about robotics is the system is great, right? Just like a Tesla autopilot is great, but you can introduce error into the system, right? When you think of all the robotic arms that build your spaceships, right? There's no human inside there that's checking the robotic system, right? They're all very accurate. So the system inherently is accurate. All of these techniques are trying to prevent introducing error. Just like when you're sitting in your autopilot car, if it's going the right direction, you don't take the wheel and change it, right? It's accurate as is unless there's something unexpected. So that being said, you can see here, the arm is sending me to, this is the right L3. So in terms of the steps, the first will be what I call the robotic knife. Some of my residents call this the ridiculously large knife, comically large knife, or the axe because it's a 22 blade. But it goes down the arm. You can see all the instruments are perfectly coaxial to the arm, so I'm not trying to push on anything. It's straight in and out. This knife goes straight down to bone. I lengthen the skin incision to make room for all of the instruments. Once this is down, the navigated dilator goes down. This is just a dilated instrument. So this is a tissue dilator, tissue protector, and you can see here I'm down on bone. I don't force anything down. It stays down on bone and protects the tissue. The next is the drill. So like most things, to help prevent skive, which was such a huge issue in all of the first iterations, everything starts in the air, right? So this is just starting right in the air before I touch the bone. Feel for the bone, start in the air. This goes all the way down. There's a positive stop at 30. Dr. Skaggs gave a great talk on all of these technologies to help prevent fatiguing. Normally, I do all of the tap and screw on power. Unfortunately, we don't have a power system here, so I'm gonna have to go back to the prehistoric tools of handles. But imagine this on power, right? So here you can see the tap also going down, that tract. And then typically on power, I'll tap most of the tract of the pedicle screw. And then once the tap is done, then all of the instruments come out. So tap comes out, the cannula comes out, and then typically again under power, but here we have a handle, the screw goes down. And again, you can notice as I place everything down, it's all very light touch, right? If something is not going down, don't force it. You just gotta go down in terms of light touch, and you can see there on the screen, the screw in purple going down the pre-planned tract. Right? And to be honest, that is it. The whole idea of robotics is to simplify and partially automate what used to be a very difficult part, and still is in a variety of different types of procedures. But by partially automating this part of the surgery, just like Dr. Sardar said earlier, go ahead and send it to the next level. You can now place your pedicle instrumentation, get your bony fixation, and essentially move on with the case, move on with the rest of your life. As Dr. Konko said, Dr. Uribe has said, time is precious, time is important. And by simplifying this, especially with everything on power, with guidance here, you get your screws down to 30 seconds to a minute, and again, you move on with the rest of the case. So I have Jonathan here, he's gonna put in the rest of the screws for me. Again, he's showing the robotic knife going down. Because the arm is rigid, here you physically move the skin to open up the skin incision to make room for all of the rest of the instruments. Once the knife goes down, this is the navigated dilator and the tissue protector. Again, you don't force it down onto the bone. Once you're down on bone, you just leave it there. The dilator comes back out. After that is the drill. The Midas drill has really been a game changer in terms of preventing skive, because now you have a burr that creates your pilot tract. And as you notice here, the navigation system is there, but you can ignore it almost for the most part for the drill and the tap, because the arm is guiding you down the entire way. Once the drill is done, here's the tap. The tap does not have a positive stop, so you just want to be sure of your depth. You can look at the screen to make sure you're going down in appropriate depth. Sorry, I think I put it in reverse for you. If for some reason the screen is not working, the arm is still accurate, and there are depth gauges on the tap itself. So just like doing a perk case, you can just go down 25 to 30, make sure you've tapped your pedicle, and then reverse back out. So once the tap comes back out, then the screw goes in. Being a terrible rep, I didn't load my screw. I understand how difficult that job is. So here's your screw. And the screw goes down, right? And again, I don't mean this to be reductive, right? But as spine surgeons, historically, we took such pride in putting in pedicle screws accurately, and they should be placed accurately. But we're getting to the point where your level and skill as a surgeon should not be and isn't going to be anymore based on the accuracy of your pedicles or the placement of your pedicle screws, but how good of an outcome you get, or how much lordosis you get, right? Or how happy patients are.
Martin,
yes.
You hear me?
Yes.
Okay, I'm gonna ask you $1 million question, okay? Let's see how you handle this one. So, how do you know that the robot is, you're telling me you can, like the car, you turn the windows down, I mean, you make it dark and it keep going. But what about if your navigation is off? How do you know that the spine didn't move?
Correct.
Is any mechanism that you can tell me 100% that spine is still right there?
Yeah. So that's a great question. And I think as good as these systems are, it's always very healthy to have a bit of critical awareness, right? So, there are people who own Teslas who go to sleep and let the car drive. My wife owns a Tesla. We definitely don't sleep, right? So even though we set on autopilot, our hands on the steering wheel, and it's just safer that way. Yeah. Just like with the robotic system, you can't ever shut your brain off, right? And so
it means like when you're in the car, your eyes, you see the car is doing the right thing. You see the road. How can you see the road in here? You may need to take an X-ray or something. Yeah. I just wanted to know. I mean, what is your? And don't take me wrong. This is everybody. This is a hard question for all of us, for every system. You don't need to have the right answer, because I don't think there is not technology. But the question is, how you mitigate the possibility that the navigation is off, which happens a lot, and drive me crazy all the time when I do these cases. I personally I set up the fluoroscopy on AP super high, and once in a while I take a shot, make sure that things are not totally off.
Yeah.
But the question is, what do you think? How can we mitigate this? Because it seems like the industry, no one hasn't been able to come with a solution.
Yeah. I would say that in my mind, I break it down into two separate areas. The first is preventative, and the next is investigative, right? So there are things, just like with navigation, you can do to help prevent introducing error. Things like not moving the patient, things like light touch surgery, things like having your neuromonitoring tech just turn off the SSEPs, right? So the patient's just not moving. So there are preventative things that you can do. But to your question, how do you know if something is off? So there are two types of errors. The first is if you take a look here, right? And so, for example, you can actually leave that screw there. So, for example, this dilator is coming down, and it looks like we're right on that screw, right? So this looks like we're on, okay? What if, for example, something has moved? Like, say you weren't looking, and someone just moves something, and you get something that looks like this, right? So this looks terrifying, right? I mean, it looks like the dilator is in the canal, it's at the wrong level. So which is correct? Is the system correct, and this dilator is in the canal? Or is the system wrong? And there's two ways to find out. And the first is that we can recalibrate the arm with the navigation, right? So like I mentioned, there are two separate systems. Can you go ahead and send to the snapshot? So in this way, we can have the arm hold, and can you hand me the gingerbread man?
One of the things that you can also do is, prior to putting in every screw, you put in the probe, and you see if as soon as the probe touches bone, you know that it's touching bone by how it feels, and then you look up and see if that is consistent. So I mean, it's like with every level, as you get further and further away from the point of reference, it gets less and less.
You can send it back to that same.
But you always can sort of troubleshoot and double check and make sure that what you're touching is bone.
Yeah.
But you're right. It's a blind procedure.
Yeah. And so, that's also the other check, because if this, say I put this down and now we have accuracy again. So this type of error was, say, a navigation error that was not matched and registered to the robot. But say we did that check, we rematched the system, and I put this down and it's still off, then we know that the patient has moved, right? So if the patient's moved, then you would go in and re-register the system with 2 sets of x-rays. I think the most dangerous error, which still happens, is if everything looks correct, right? So for example, if the navigation is on the robotic system and I put this down here and it shows that I'm in this screw, but what if I physically just move the patient, 2 feet away from me?
Correct.
Right? So it's obvious that the patient has moved, and I can see it with my own eyes, but the system doesn't see it as such. And that's obvious. But what if the patient moves, to your point, 5 millimeters, right? Now you have a medial breach or a lateral breach. Those are, I think, the most difficult errors that we don't have a solution for. Yeah. And those are the types of errors that are meant to be prevented with all the preventative measures in trying to not introduce error to the system. Because that's going to be the difficult one, the most difficult one to catch.
And something, Martin, that also I've been struggling a lot in my own experience is that, it's not very uncommon that the patients get a little superficial and they cough and they move and you get terrified, I always work very hard also with anesthesia, as you say, trying to mitigate things is make sure that the patient is deep enough so it's not even a single chance they're going to cough or something, because little series of coughing episodes can take the whole patient away from the regular navigation. And my big fear is this one. And this is a good example. For example, you see how sometimes the airplane crashes happen. So the pilot get into a plane with everything working perfect into a big cloud. Somehow there is some weather, starts stalling a little bit. Then at some point, he has no reference what is up and down. And then suddenly the pilot knows how to do everything. The instruments are fine, but he doesn't know what is the ceiling, what is the bottom. And then whatever he does is going to be worse. And then that's how the accidents happen. It's a lot of examples on that. How can you prevent to get into that case scenario where, as you mentioned, is like, everything, you're good, you know what's happening, you know what to do. Actually, the robot is holding exactly the position that whatever position is, and the navigation is lost. So, you're perfect, but you're lost in the space. So how do you think first you can identify that and how you mitigate? Because this is the thing that happened. I don't know if you guys follow in social media. I put in a series of big, bad executions on robotic cases, navigation, and that, just trying to make people aware that what Benzel always say, a fool with a tool still is a fool, yeah? So I don't know, you can elaborate that, because this is the only way that we can really learn and be aware and make these things work.
Yeah, no, I think it's something that's a very good question, because, in your analogy of the airplane, the airplane has an autopilot. You step into a 747, you could turn on the autopilot, and a child can just take the plane up, right? So what makes the difference between a child and an experienced pilot? And I think it's all these fundamentals, because it's all this spatial awareness that you had mentioned earlier, all of this clinical awareness where this is partially automated, right? Just like your car is partially automated. But what makes the difference between a race car driver in a Tesla versus, my teenage kid in the car, and its experience. So experience still matters, right? Understanding, putting in screws with fluoroscopy or navigation, understanding how that works still matters, because at the end of the day, you should have a low threshold to abandon the robot, right? And the only way you can do that is if you understand how to put in these screws or bony fixation parts in other ways. So over-reliance on technology is certainly a detriment as well, right? And I think it's all of these things that, although things are getting better, right? I mean, we have calculators, and we have supercomputers and quantum computers, but we still know how to do math on a piece of paper, right? If the autopilot fails, we can still take control of the wheel and brake and go. And same thing with this system. It's meant to make things easier, but it's still not perfect and may never be perfect. Just like, I'll always want my American Airlines pilot to be a retired, F-35 Raptor pilot, except he's now just flying something really easily with the assistance of his autopilot in the aircraft.
Dr. Pham, Dave Skaggs, can I ask you a question?
Yes, please.
My disclosure is one, I love learning the robots and navs. I use them all the time now for spondy cases. It makes it so much easier. But I've seen a number of screws like in the canal at T10, T11, T12, completely missing the pedicle. Is that something that one should be able to feel as you go down with the drill, or do we just give up the idea of feeling anything?
So I've also seen that. Or heard of it, rather. I'm lucky enough that it hasn't happened in my practice or at my institution. So anecdotally, I can only say that it's either a system failure. I mean, all the robotic systems can have their own quirks and errors, or a technical failure, right? In terms of the technique, whether, if you're pushing down, especially in the thoracic spine, and you push too hard, you're naturally going to skive medially because of the slope of the transverse process in lamina. So all of these things can make that occurrence make sense. But I wouldn't say that it should be a common thing, because it shouldn't. And I put in screws in the thoracic spine. I put them in PERC, right? I put them in open. I would say that use of the robot in open surgery can be a bit more cumbersome because you have to do more registrations. So I think the power really comes in when you're putting in PERC screws up in the thoracic spine. But that being said, I do think that it really just comes down to technique. And if that's happening, figuring out if it's a system error and there's an error with the robot, or potentially a technical error with the provider.
So watching you use that drill, it seemed to me like you were going up and down a little bit and feeling and making certain that you were in the bone the whole time. Do you pay attention to that?
I do. So you do certainly lose tactile feel. And, training I trained at USC. I was there. You probably wouldn't remember me. I was a lowly resident rotating through the Children's Hospital when you were the big man on campus there. But I also trained in open technique. We freehanded all of our screws from T4 down to ilium. And going from that, right, feeling the cancellous bone, feeling the tap, feeling the screw, and then going to nav, where you lose a little bit more, and then going to the robotic system, where you can't even wiggle around in an ice cream cone sort of shape to get a feel. It's a huge loss of haptic feedback. That being said, it's still there, right? When you put down the drill, you can still feel it hitting bone. When you put down the tap, you still feel the bite of that tap. And there are times where if the screw is malpositioned, which happens, especially in the earlier days prior to the Midas for Mazor, screws would typically be malpositioned laterally, because they would skive off the facet laterally and become a laterally positioned screw. And we would start to get a sense of that with the tap in the screw, because it wouldn't bite into the bone. So there's certainly haptic feedback that's there that I pay attention to, but it's much, much less. And I would say that I'm lucky enough to be able to compare it to an open experience. If you're training on this, then it's something I think a lot more subtle that you have to pick up from scratch.
And one of the key things that you had mentioned earlier was the multiple registrations. So, if you're using the single registration and relying on that, pelvic reference point, and then using that for the T10 pedicle screw, I think that's part of the problem. Is it's like the distance away from the reference point may have something to do with it being off, and so I think you may need more than one scan with the O-arm if you're doing a scan and plan versus if you're using fluoro registration with the 2 fluoro shots. I definitely think it'd be good to split it up into two sessions.
Yeah. No, I do think that all of this is still I mean, the Mazor robotics systems have been around since 2005. This iteration has been around since 2015, and you're going to see the Globus, which is the other robotics platform we have here. They're all fantastic, but when you consider the big leap we're making into a partial automation of a task, it's still very early. So figuring out things like best practices, like registrations and mounting points, and where the frame should be, whether it should be on the robotic arm or the patient arm, it's still very, very new. And I would discourage anyone from drinking the Kool-Aid too much between one particular industry or another, because it's all a learning process, and it all should get better as time goes on.
Thank you very much, Doctor.
All right, thank you.
That's wonderful.
Thank you.
All right, it is 4:30, but we do have Dr. Kazim.